So if you're watching this video and you feel any guilt from actually not having filled this out, I'm going to ask you to pause it and then go and actually fill those out. Don't feel guilty. Build trust. Me and you, we got this. But if you have completed it, good job, and you can continue watching with no guilt. And so, when we think about these answers here, it's basically, I like this image because it groups almost everything relatively nicely. And so if you are a visual learner, this might help you, and the color coding might also help you. If you have your handout and you want to color code your handout, might decrease your cognitive load and make that more simple. So all of these are going to be sodium channel blockers. These four are going to be able to block these voltage-gated calcium channels or change the activity of those calcium channels. One thing to note, the lamotrigine, we'll see in the explanations, they can also inhibit voltage-gated sodium channels. And then when you look at the green ones, these are going to affect GABA signaling, specifically binding to and activating the GABA A receptors. But then all of these other ones over here, and there's a couple others that are not listed here, but they also increase GABA function. So all these ones over here. And hopefully what you noticed is that the valproic acid or the valproate has multiple targets. The topiramate also has multiple targets, and then one of the special ones is the levetiracetam that's going to have a special function and prevent the neurotransmitter release. So if we take all of those general mechanisms and we get into a little bit more of the specifics, full disclosure, sometimes we don't know exactly what everyone is doing. A couple of them, they were originally designed to do one thing, but it turns out that they're doing multiple. But we start with that phentoin, so that's that sodium channel blocker, and it's a voltage-dependent block of those voltage-gated sodium channels. And what happens is it allows them to open, so you can have your action potential, and we don't know the exact mechanism of how it's doing it, but it's going to increase or prolong the inactivation of the channel. So if you remember from our action potentials, we have the voltage-gated sodium channel, which opens at a depolarized membrane potential, and then there is an internal inactivation that happens, and then what this drug does is it keeps that inactivated longer so that you can't have more action potentials going through. Okay. So pentobarbital is happening in a different spot, postsynaptically, and basically just binding to GABA A receptors and keeping them open longer, so increasing the inhibition. Carbamazepine, I always have to think about how to pronounce these. Carbamazepine, again, a sodium channel blocker, and doing the same thing, increasing the sodium channel inactivation, or enhancement of sodium channel inactivation. Valproate is one of those, that valproic acid, which has multiple targets. So it's going to be a GABA potentiator. It's going to inhibit glutamate receptors, specifically NMDA receptors. It's going to block sodium channels, and it's going to block calcium channels. Remember how we had 4 different things that these drugs could do? Valproate does all 4 of them. And this is the one that is teratogenic and is going to cause birth defects. So right here, we write it down later, but also right here, right, not for women who can have kids. All right, clobazam is a GABA potentiator, so again, increasing the inhibition. Binds at the same site as benzodiazepines in the GABA A receptor, keeps them open longer. And now, so here are the two that I always find confusing because they have GABA in the name, but they actually don't affect GABA. They affect the voltage-gated sodium channels. So gabapentin and pregabalin do the same thing. And they're going to block a specific subunit of the voltage-gated calcium channels and block specifically at glutamate terminals and prevent neurotransmitter release. Both of those are going to do the same thing. And just a reminder, I'm going to kind of go through these relatively quickly, but you're welcome to pause so that you can make sure you have everything written down. And so next three are, again, those voltage-gated sodium channels. And as most of these drugs, we don't know the exact mechanism. So in these two, we're going to block the voltage-gated sodium channel somehow. Oh, and I actually meant to mention, one of the things that these drugs were created, so phenytoin was actually created early 1900s. I feel like it's 1908, but anyway, somewhere around that time. But we didn't actually understand that it was going to be good for seizures until 1936. And if you think about what we knew back in 1936 about how action potentials function, we were still really figuring it out. And so the actual mechanism of action wasn't known until much later. So made in the early 1900s, used for seizures kind of starting around 1936, but actual mechanism of action wasn't known until probably around 1986, 50 years later, because that's the first I can find a paper that says the mechanism of action of it. So coming back to these, after my tangent, you've got, these were the sodium channel blockers. Lamotrigine is one that does both, so blocks voltage-gated sodium channels and voltage-gated calcium channels. And in this, for voltage-gated sodium channels, it can selectively bind and inhibit those channels, and then it also can inhibit specific types of calcium currents in specific regions of the brain. So that specificity actually makes it a better drug because it's not inhibiting everywhere. So there are specific high voltage activated calcium currents, often in the hippocampus, which is sometimes where seizures begin, that the lamotrigine can inhibit that activity. And we had mentioned the levetiracetam is going to have a unique target that we hadn't talked about. But going to prevent neurotransmitter release, and it does that by binding to a specific synaptic vesicle protein that's going to regulate that vesicle release. And that protein is SV2A, and it binds, and it probably somehow prevents other proteins from binding to it, and so that you don't get the vesicle release. But, again, the exact mechanism is unknown. So the drugs are created, they have a relative target, and we can see in experiments that it's doing this, but we don't know exactly how it works. And for that one, I just wanted to come back up here and just recognize, so here's the vesicle, glutamate is in the vesicle, this SV2A is a protein that is here that's going to help the neurotransmitter vesicle bind to the presynaptic membrane and release the neurotransmitter. Levetiracetam, which I always have to, again, long one, levetiracetam, is going to inhibit that SV2A protein somehow. And finishing up for our last four, topiramate, again, like valproic acid or valproate, has multiple targets. And one thing that is a little mnemonic for that is that valproate and topiramate are the only ones that end in ATE, and those are the only two that have, some of them have two targets, but only a few of them. So these two are the ones that both have multiple targets. And so for topiramate, it's going to have that increased GABA activity. Glutamate inhibition in this one, instead of affecting NMDA receptors, we are inhibiting AMPA receptors. And then can block sodium and calcium channels. So again, you've got all four things. You've got sodium channels, calcium channels, GABA activity, or increased GABA activity, decreased glutamate activity. Then we go to our last ones. Zonisamide blocks sodium channels, and in this one, it changes the fast inactivation threshold of voltage-gated sodium channels. So it basically just makes the inactivation happen faster. And then perampanel is going to block, this is the only one that only blocks glutamate receptors. And it's specific for AMPA receptors. So it's going to block AMPA receptors. Going to be a really specific treatment. Lacosamide, again, blocks those sodium channels. Again, enhanced activation of voltage-gated sodium channels. So, going back to our big picture, these are just specific examples of ways that you can block these main four steps. And now that we know the general mechanism along with the specific mechanism, we can think about how or which ones are going to be best for different types of seizure activity. And that's what we're going to look at in the next video. So we're going to think about what's going to be best to prescribe for specific individuals who have specific seizure types, and what is going to be the best treatment for them, because some of these we can't use for women of childbearing age, and some of them are going to have more negative side effects based on their mechanism of action.